Professor Dr. Mukesh Kumar Taneja is there, sure. And moderator Dr. Ikeda and moderator Dr. Jayashri Barua kindly be there on the dais. So we start with the first presentation, that is the toric IOL alignment using intraoperative image guided versus femtosecond laser enabled capsular marks. And this is to be presented by Dr. Shubhangi Shivale. Dr. Shubhangi.
बोलिए तो बिल्कुल सेकंड इनका कर दो सर।
हाँ उनका कर देंगे, आपका कर रहे हैं सर।
इनका नाम है सत्यजीत सिंह।
हाँ ये लेगा
अच्छा नहीं 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 मिल गया आप भी कर कोई देख के आ गया कि हाँ फटाफट कर दे। डेट आज है सेकंड 2/4/1925 टाइम 10:30।
Good morning, one and all. My topic is comparison of post-operative outcome following toric IOL implantation using an image-guided versus femto-laser-enabled capsular marking system for intraoperative IOL positioning. I have no financial interest. Toric intraocular lenses were developed to help the patient with astigmatism to achieve post-operative spectacle independence for distance vision. In order to achieve excellent post-operative outcome and patient satisfaction, it is must for surgeon to accurately calculate the power and axis of toric IOL preoperatively and then to align the IOL along the correct axis at the time of implantation. Callisto, it is markerless toric IOL alignment. Biometric data and scleral reference image from IOL master taken from IOL master 700, and it is then transferred to Zeiss forum in DICOM format. Callisto eye tracks the intraoperative image in real time using limbal vessels as guide and pairs two images very closely so that they can be precisely matched. The target axis is displayed as overlay on the live image for precise toric IOL alignment. This compilation image is injected into the eyepiece of Lumira 700 or projected onto the screen of RTO 800 3D microscope system, creating visual aid for toric IOL alignment. IntelliAxis, it is automated iris registration mechanism. The pre-op diagnostic data is transferred wirelessly from Pentacam and Cassini corneal shape analyzer to Lensar laser system. During treatment, Lensar can recognize the pattern of iris, patient's iris, and recognize any cyclotorsion and perfectly align the incision placement. IntelliAxis feature of Lensar, which cuts the capsular axis by making two small nubs in steep axis of the eye, facilitate the matching of toricity marks on toric lens. Purpose of my study was to compare the post-op outcome following toric IOL implantation using image-guided versus femto-laser-enabled capsular marking system for intraoperative alignment. It was a two-arm prospective comparative study. 60 eyes of 60 patients, 30 in each group, undergoing femto-laser-assisted cataract surgery using Lensar laser followed by Technis toric IOL implantation were randomized to receive intraoperative toric IOL alignment using Callisto eye or the IntelliAxis refractive capsular axis. Inclusion criteria: healthy eyes besides age-related cataract between 40 to 80 years. Eyes undergoing femto laser assisted surgery with implantation of Technis toric IOL, regular corneal topography, and corneal astigmatism within the range of 0.75 diopter to 4 diopter. For all eligible patients, following tests were performed: measurement of UDVA, BCVA, manifest refraction, anterior segment examination, posterior segment examination, non-contact tonometry, pentacam HR, specular microscopy, macular OCT, and IOL master 700 and toric IOL power calculation using Barrett TK toric calculator with total keratometry. Post-operatively, eye trace was done to check the IOL rotation with toric alignment check feature of the eye trace. This is the eye trace image of the post-op 3 months of IntelliAxis. 0-degree rotation in this particular patient was seen. Post-op 3 months of Callisto, in this patient 21-degree rotation was seen. Toric IOL is being injected. the Z align, these three blue lines are Z align of the Callisto, and we have to match the toric marks on the intraocular lens with the these blue Z lines. Here the IntelliAxis Lensar laser performs IntelliAxis capsular nubs while doing capsulotomy, and after injecting the lens we should mark the toric marks on the intraocular lens with the capsular nubs as it is shown in the video. So with capsular nubs, toric marks were matched. This is the preoperative data. Post-operatively, in post-op 1 week, mean cylinder in Callisto group was minus 0.20 plus minus 0.42, and in IntelliAxis group it was minus 0.07 plus minus 0.23. At post-op 3 months, cylinder was minus 0.18 plus minus 0.40 in Callisto group, whereas in IntelliAxis group it was minus 0.04 plus minus 0.21. Deviation of the intended axis at 3 months was 3.2 plus minus 1.68 in Callisto group, whereas in IntelliAxis group it was 2.66 plus minus 1.72. These are the graphs at post-op 3 months. Refractive astigmatism was less than 0.5 diopter in 93% of the eyes in Callisto group, and less than 1%, less than equal to 1 diopter in 97% patients, whereas in IntelliAxis group it was less than 0.5 diopter in 97% and less than equal to 1 diopter in 100% patients. Previous studies by Dr. Tim Schultz, he compared the toric intraocular lens alignment between femtolaser assisted capsular marking and digital marking, and concluded that both methods showed excellent result for toric IOL alignment. However, femtolaser assisted capsular marking was significantly more precise than digital marking and showed good refractive result. Whereas another study by Dr. Danwin Cow, he concluded that IOL misalignment was significantly lower in femtolaser assisted capsular marking group than in manual corneal marking group, and long-term preservation of capsular mark is helpful for evaluating the rotation of toric IOL. Conclusion, in our study we concluded that both systems were safe and effective for intraoperative toric IOL alignment and resulted in significant reduction of preoperative astigmatism. However, IntelliAxis refractive capsular axis intraoperative toric alignment achieved significantly less of postoperative cylinder compared to Callisto Z-align alignment, possibly due to better accuracy of iris pattern registration. In addition, capsular marking offers the possibility to avoid parallax error and evaluating post-op IOL rotation. These are my references. Thank you.
Very nice, wonderful. Are there any other femtosecond laser which have a facility for capsular marking besides Lensar?
Capsular marking, no.
So that's the advantage with
Yeah.
this. And have you any specific choice about type of lens which will undergo less rotation, particularly toric lens, so that your thinness in alignment, is maintained and you don't have to reposition it?
So we
Any specific thing that you recommend for the IOL also? No.
no, sir. We tried only techniques.
Dr. Bayala, you'd like to ask something?
I think, yeah, the Lensar in particular is a good machine in this respect, that we can mark the things where to place the lens, and which is very important in cases of the toric lenses. Well presented. Thank you.
Can we
Thank
invite
you,
Dr.
sir.
Satyajit Sinha? He has to.
Thank you so much.
Dr. Satyajit Sinha to speak, because he has to attend other session, and he's going to speak on cataract surgery in patients with potential risk of post-operative diabetic macular edema. Dr. Satyajit Sinha.
सबसे ऊपर में
स्विच कीजिए.
So, respected Chair, a very good morning. A very warm welcome to everybody to this APO AIOS conference. I'll be speaking on cataract surgery in patients with potential risk of post-op diabetic macular edema. We are doing cataract surgeries day in and day out, but there are some patients who we are dealing with who have sometimes uncontrolled diabetes or are long-standing diabetics, and those are the patients who are potentially at risk of DME, and we will be talking about those patients. I have no financial interest in any of the products mentioned here. I can't see that mouse in the laptop here. आ गया. आप ही चला दीजिए वहां से. अभी आया तो था वो नीचे. नीचे से प्ले करना. So you're doing a perfect surgery. You are very happy with your axis. You have a little cortical matter left, and these are the patients who are diabetics. You have controlled them. They are long-standing diabetics, and when everything is going normal, you don't have to worry about anything. But if something goes wrong, and then there is a cascade which starts, and complications go on becoming more and more deeper, and that is when it becomes difficult to manage things. So in this, you will see that there's a little cortical matter remaining, and if you see carefully in the center, you will see a speck of cataract remaining over there. So first we remove this remnant cortical matter, and now I am tempted to go and chase the little speck which is there in the center, and I'm trying to polish it, and there is where I hit. Can you see that posterior capsule tear? So this is what I wanted to show. So we are diabetics more prone to endothelial cell loss during phacoemulsification in more than normal subjects? And the answer is yes. Is the posterior capsule more fragile in long-standing diabetics? We still have to know. Are diabetics more prone to diabetic macular edema post-cataract surgery as compared to non-diabetics? Yes. The progression or recurrence of DME following prompt cataract surgery is a profound disappointment both for the surgeon and the patients. Patients with diabetic retinopathy are more predisposed to poorer post-operative visual acuity and are at a higher risk of complications after cataract surgery when compared with those with diabetic retinopathy. The risk is even higher in the presence of pre-existing diabetic retinopathy. The risk of developing post-operative DME is directly proportional to the severity of diabetic retinopathy. So in patients who you see diabetic retinopathy and you are planning to do cataract surgery for some reason, if the visualization is not good, if you are planning to do it before, then you keep in mind that there is a higher chances of DME. In diabetic patients who underwent cataract surgery, macular edema can result either from pseudophakic CME or from a pre-existing DME itself. Both entities are characterized by fluid accumulation in the retinal tissues in macular region, but these two diseases have to be distinguished. There's minimal diabetic retinopathy, and the absence of exudates point more towards pseudophakic CME. DME often presents with an underlying diabetic retinopathy, exudates, and macular edema. The risks are significantly higher than for patients without concurrent or previous history of DME at the time of surgery. The management of pre-existing DME with visually significant cataract is a cleaning and conundrum because you are in a fix of which one to do first. Deferring cataract surgery until DME is adequately treated may not always be an ideal situation like we have been taught conventionally because of prolonged visual impairment and maturation of cataract jeopardizing surgical safety and monitoring of diabetic retinopathy. However, with patients with pre-existing diabetic retinopathy, if the fundal view is good, then you can go ahead and do the management of diabetic macular edema first and then do the cataract surgery. In these uncontrolled diabetics, you must get HbA1c also done. It's known to be a significant risk for diabetic retinopathy. And the management of concurrent DME at the time of cataract surgery is much more challenging because of DME is unlikely to resolve spontaneously. I will skip these and go to the management directly. There are anti-inflammatory drugs which we must use in these diabetic patients before we are doing cataract surgery, regardless of whether you are anticipating DME or not. Your use of topical corticosteroids also we are using to reduce the inflammation, but it also helps along with NSAIDs. And in some cases, as we know, we need to do lasers also. NSAIDs are associated with side effects such as transient burning sensation and epithelial corneal defects. So it's advisable not to tell them to use for long period of time, even after the cataract surgery, after 3 weeks to 4 weeks. Although the mechanism of action of topical steroids is similar to those of NSAID, a topical steroid is more inferior in prevention of pseudophakic CME, probably due to its lower penetration in the eye, and there are more side effects like increasing the intraocular pressure. The addition of a topical steroid did not have significant effect on the lowering the chance of postoperative DME, but should be prescribed to suppress other forms of intraocular inflammation. We also know that intravitreal injections are there, which we are using regularly. When you see a DME, it's good to manage it 14 days earlier and then do a follow-up, see the macular thickness and then plan your cataract surgery. See the macular thickness on OCT. Intravitreal injections of corticosteroid and anti-VEGF as first line of therapy have demonstrated safety and efficacy to treat diabetic macular edema. These are the different anti-VEGF injections, which I won't go into detail. This is Ozurdex, and we are also using lasers. Now, when you have complications like prolonged surgical time, excessive manipulation, excessive use of phaco energy, or if you have a posterior capsule tear, as I showed in the beginning, then the management becomes even more difficult. If you have a non-intact posterior capsule, if there is prolapse of the vitreous, there is iris chaffing, if there is retained lens matter, if there is prolonged operation time, then the risk becomes even more. So thank you very much for your patient hearing.
Very nice, excellent. Dr. Ikeda, would you like to ask some, have clarification?
I mean, we all know that we have to be very careful in diabetics, and I think one thing that really helps is doing a preoperative OCT for all the diabetics that we are operating, so that sometimes we might miss macular edema when we are doing a fundus examination. So if we have subclinical macular edema or something that we have missed because of the cataract, then preoperative OCT and documenting it really helps in these patients.
Yes.
Thank you.
Thank you very much.
Excellent, Dr. Satyajit Sinha, as always.
Sir, a query is there.
Yes.
If a patient is having a pre-existing DME and is subjected for cataract surgery, so would you like to dry up the macula first by giving preoperative anti-VEGFs, or would you take up a thing like Ozurdex along with cataract surgery? What's your take?
So there are two parts of it. One is the management part per se, what you are asking, and the other part is good visualization. Depending upon which grade of cataract you are dealing with when you are anticipating diabetic macular edema. If you have good visualization, it's better to treat and manage the DME first and then go ahead after 2 weeks and 1 month follow-up and then do the cataract surgery. And but if you do not have proper visualization, if the vitreoretinal surgeon finds it difficult to manage, then first do the cataract surgery and then manage the DME.
An Ozurdex along with phaco should work in that scenario?
Some surgeons are doing that. They are giving Ozurdex at the same time on the same table during the surgery also.
Thank you.
I think as you have explained, doing HbA1c is very, very important in these cases, because sometimes patients comes to us where he says he's okay with the blood sugar levels for the last few days, 3, 4, 5 days, and HbA1c is 9.5 or something.
Yes,
these are the cases which land us into trouble.
Yes,
and
sir.
he has rightly mentioned. Thank you so much.
Wonderful. And Dr. Uma
Thank you, sir.
Shroff to be the next speaker. She is going to speak on a study to understand the effect of pupillary dilatation on optical biometry and IOL power calculation. In the meantime, I will just go through the other speakers who are present. Dr. Akansha Sharma, are you there? Yes. Dr. Priyam Gupta? Yes. Dr. Alisha? Yes. Dr. Akash?
Sandeep.
Yes. And Dr. Soima? Yes.
Saujanya.
Dr. Saujanya? Yes. Dr. Nawab? Yes. Dr. Deepak?
Deepak Digambar.
Dr. Deepak Digambar? He is not there. And Dr. Happy? Dr. Happy Kaur? Not there. All right. So, Dr. Uma Shroff to speak.
Can I request all the speakers to kindly stick to the time so that we can finish well within time? 5 minutes, please. Thank you.
Good morning, one and all. I am Dr. Uma Shroff, and I am going to present my research paper on a study to understand the effect of pupillary dilatation on optical biometry and IOL power calculation. As we all know, the cataracts. The slide is not going.
Can we have some AV support and the timer as well?
As we all know that the cataract surgery is no longer just a vision restoring procedure but a refractive surgery, and unaided 6/6 vision is a necessity nowadays and not an exception. And in such scenario, accurate IOL power calculation becomes very important. As we can see, the pupillary dilatation can affect the final IOL power calculation in various ways, like alteration in the effective lens position, ACD measurements, fixation issues, keratometry variables, etc. As we all know, SRQ formula used to consider the A constant of IOL, power of cornea and axial length of the eye, whereas Barrett formula also includes anterior chamber depth, lens thickness and wide to wide corneal diameter in addition to axial length and keratometry. This is the review of literature. Few papers have suggested that there is no clinically significant effect of pupillary dilatation on IOL master measurements, axial length, corneal power or IOL power calculation by SRKT formula, but Haig's formula is a little more susceptible. Another study by Catherine et al. Suggested that dilating pupil did not adversely affect the IOL power calculation, whereas a study by Teshigawara et al. Suggested that Barrett formula was significantly affected in terms of ACD lens thickness and wide to wide. Another study by Noha suggested that there might be myopic surprise with pupillary dilatation, and another few studies suggested that it was insignificant. So this is my study. We selected 156 cases of cataract surgery, and we compared the IOL power measurements, axial length, keratometry values, anterior chamber depth before and after pupillary dilatation in the same patient. Inclusion criteria included more than 18 years of age, senile cataract, complete IOL power measurements available, both dilated and undilated states, and uneventful cataract surgery. Exclusion criteria was axial length less than 20 mm or more than 24 mm, ocular pathologies such as glaucoma, retinal detachment, dense cataracts, etc. Measurements were done for axial length, anterior chamber depth, K1, K2 IOL power, both before and after pupillary dilatation in the same patient using IOL Master 500. These are the results. The mean ACD and mean AL were significantly changed after dilatation, but there was no significant changes in mean K1, K2 or axial length pre and post dilatation, and mean IOL power calculations were not affected statistically significantly using both SRKT as well as Barrett toric formula. However, if we look at the individual readings, we can see that the SRKT formula 67 readings remain unchanged, whereas Barrett formula spherical power only 46% readings remain unchanged, and 31% were having a positive change and 23% had a negative change. Similarly, for cylindrical power calculations using Barrett formula also, only 48% readings remained unchanged. Means more than 50% readings were getting changed either positively or negatively post dilatation. However, we could not study in details the effects. Our findings that AL and ACD were significantly changed, aligned with the previous studies by Huang et al., Teshigawara et al. But there was no significant change in K1, K2 or mean IL power using SRKT or Barrett formula. However, 50% readings got changed, as I already mentioned. So individual IL power readings are being affected even though we are not seeing any change in the mean values. Dilatation may introduce variability necessitating caution in biometry interpretation. Residual refractive error analysis suggests no significant impact on final outcomes. And here are the future considerations that ACD, AL, corneal curvature, effective lens position all influence the IL power. So further study is required. So prospective multicentric cohort study might be a better option to go for. So here is the conclusion. Pupillary dilatation significantly affects ACD and AL but does not affect keratometry or mean IL power calculation. However, 50% of the individual IL power readings are being changed. Especially Barrett formula is more susceptible as compared to SRKT formula. Performing biometry without dilatation may simplify the preoperative assessment, and further prospective multicenter trial is required. Here are the limitations of my study. It was a retrospective design and sample size was small, and there was variability in individual pupil dilatation. Here I am in references. Thank you.
Hi, nice paper. So I just wanted to ask you one question. Since you said that with dilatation, the axial length and the ACD increases, and of course it's intuitive as well, and you showed in the study that the keratometry remains the same. Could you explain then why the IOL power is not changing significantly, why it's not statistically significant, since the change in axial length and ACD is statistically significant?
Yes, ma'am. So the change is basically either in the positive side or the negative side, and the overall effect is being neutralized in the formula. Maybe the formula are robust because they have such a large database with them. So probably the final IR power calculation is not much affected despite the mean axial length and mean ACD being.
So I thought both were increased, right? I don't think there was an increase and decrease, but both were increased. Probably one of the reasons could also be because we have a smaller sample size. That's the reason why I couldn't see a significant change, because as if I remember correctly, you said that both are significantly increased. It's not just variability, but both are increased, right? So that doesn't translate into why there is not a significant change in the end. Thank you.
Thank you.
Thank you, Dr. Dr. Uma, wonderful. And it's very important take-home message that once we are detecting case of cataract and pupils are dilated, the biometry should be done when the pupils are undilated to get the most accurate readings. Dr. Bayala would like to give some hints to the speakers how to present.
I request all the speakers, because this is a competitive session, if you cross the limit of time, your marks will be cut. So we have to finish in time, and you have to learn how to finish your talk in time.
And the next speaker I'm going to call Dr. Akansha Sharma, and she is going to speak on comparative analysis of Femtis M Plus versus Panoptix Toric Multifocal IOL. Dr. Akansha.
Can you please?
Yep. In the meantime, Dr. Mukesh, you want to comment anything on the previous speaker?
That is
Usually in the literature, I think there is usually variation of 0.5 diopters. But in Uma's case, I think there was none.
All right.
Now please start. Next.
Good morning, everyone. My topic for presentation is comparative analysis of Femtis M+ versus the panoptic storic multifocal IOL. So modern cataract surgery has evolved into a refractive procedure with the advent of intraocular lenses like the multifocal intraocular lenses, which promote spectacle independence by providing good vision at all distances. One of such lenses is the trifocal intraocular lens, which compared to bifocal IOLs, they improve the intermediate vision by providing a third focus. The Femtis M+ is one such IOL which is designed for capsulotomy fixation, and it provides smooth distance from distance to near based on its asymmetric refractive optics with varifocal technology. A second such variant is the panoptic storic IOL, which is designed for in-the-bag IOL implantation. It has a unique diffractive structure which allows high light utilization. The aim of this study is to analyze and compare the clinical outcomes and rotational stability of these two presbyopia correcting toric intraocular lenses. So it was a prospective, randomized, comparative, two-arm, single-center, single-surgeon study with 60 patients in each group, and 3-month follow-up data was available. These were the inclusion and the exclusion criteria. So complete preoperative ocular examination was carried out, followed by which all patients underwent femtosecond laser-assisted cataract surgery. The Femtis M+ IOL was implanted with anterior capsular fixation, while the Panoptix IOL was implanted in the capsular bag. Both the lenses were positioned at the desired axis using the IntelliAxis technology by the Lensier, which creates two nubs on the capsulotomy margin. This is an image of the capsular axis nubs. Post-operative follow-up was done at day 1, 1 week, 1 month, and 3 months. Coming to the results, so uncorrected distance visual acuity was significantly better in the Femtis group as compared to the Panoptix group. However, at post-operative 3 months, the uncorrected distance visual acuity was found to be comparative in both the groups. The mean manifest spherical equivalent was found to be significantly better in the Femtis group as compared to the Panoptix group. 100% of patients in the Femtis group had a manifest spherical equivalent of plus minus 0.5 diopters as compared to 98.3% in the Panoptix group. Refractive astigmatism was found to be better in the Femtis group, with 88.5% patients achieving a refractive astigmatism of less than 0.25 diopters as compared to 76.7% patients in the Panoptix group post-operatively. Uncorrected near visual acuity was found to be comparable and good in both the groups, while the intermediate vision was found to be slightly better in the Panoptix IOL, but this was not statistically significant. Rotational stability was found to be significantly better in the Femtis M group. One patient in the Panoptix group had an IOL rotation of more than 10 degrees as compared to none of the patients having IOL rotation of more than 5 degrees in the Femtis group. The defocus curve showed good and comparable visual acuity at all defocus points in both the groups. Contrast sensitivity was found to be significantly better in the Femtis group at all spatial frequencies. Dysphotopsia questionnaire and patient satisfaction scores were found that a higher percentage of patients reported of glare and day and night halos in the Panoptix group as compared to the Femtis group. And vision satisfaction score at post-op 3 months showed that the Femtis M+ group scored slightly better, significantly better in terms of night vision, while the Panoptix group scored slightly better in terms of intermediate vision. So in conclusion, both the IOLs, they deliver excellent uncorrected and distance vision. The Panoptix toric IOL, it has an edge as it provides superior intermediate vision, and this is because it incorporates an intermediate focal point of 60 cm, while the Femtis M+ IOL offers better rotational stability and lesser dysphotopsia. This is attributed to its unique clip haptic design and smooth transmedial surface transition. And a higher percentage of Femtis M+ patients achieve post-operative astigmatism within plus minus 0.25 diopters. So personalized patient selection remains the key to optimizing visual outcomes and overall satisfaction. This is a picture of the Femtis M+ IOL. And this is a video which shows the implantation of the Femtis M+ IOL with its clip haptic design onto the anterior capsulotomy margin. So it has 4 clip haptics, 2 on the longitudinal side and 2 on the latitudinal side, with the help of which it is attached to the anterior capsulotomy margin, which is made with the help of a femtosecond laser. Thank you.
Excellent. Do you use, which femtosecond laser do you use in all these cases?
So we have two, sir, but we have Lenciar and we also have the Zymer, but we prefer the Lenciar because it gives us the two capsular axis nubs.
Absolutely. So you have both the elements there, the
Yes, sir.
right kind of marking, at the same time fixation is good
Fixation
and
is
it
good.
doesn't descend.
Yes, sir.
Excellent, excellent.
Thank you, sir.
And Dr. Taneja, Mukesh Taneja, would you like to add something?
Sir, did you find any complication in this Femtis?
Femtis, a few patients had come with difficulties in intermediate vision, which was seen in the post-operative 2 weeks, but that stabilized over post-op 3 months, sir.
After 3 months?
It stabilized. Because we followed them up after 3 months, it stabilized, but they reported that within 1 month, they were more comfortable with the Femtis.
Okay.
Very good. Now we call the next speaker, Dr. Bharti Kashyap. She is going to speak on comparison of flax and Varion assisted arcuate incisions and toric IOL in management of corneal astigmatism.
Good
Dr.
morning.
Bharti.
Good morning, everyone. My topic is comparative evaluation of flax arcuate incision, image guided manual arcuate incision and toric IOLs in the management of corneal astigmatism ranging from 0.75 to -1.5 diopter. The purpose is to compare the visual outcome of flax arcuate, image guided arcuates and toric IOL for the management of coexisting corneal cataract and corneal astigmatism ranging from 0.75 to 1.5. Mild astigmatism can be corrected by flax corneal arcuates, image guided manual arcuates or toric IOL. So 40% of the general cataract population has one astigmatism, and today cataract surgery is regarded as a refractive surgery aiming pseudophakic emmetropia, which makes eliminating corneal astigmatism critical. So this is a prospective comparative study of 144 eyes, single surgeon, data analysis by SPSS software version 2. So it was divided in 3 groups. Each group had 48 eyes. First group had femtosecond arcuate incisions, second group image guided manual arcuate incisions, and the third group toric IOLs. So the outcome measures were at 180 days. The change in uncorrected visual acuity from 7 to 180 days amongst 3 groups. Then difference of visual acuity at 7 days amongst the 3 group. Difference of visual acuity at 180 days amongst the 3 group. Photopic and mesopic MFT values at 5 and 10 CPD in 7 and 180 days. These are the inclusion criteria. These are the exclusion criteria. Statistical analysis was by SPSS software version 2. The demographic distribution of age and gender was comparable. The ANOVA was applied to see change in visual acuity from 7 days to 180 days among the 3 groups. And the ANOVA showed a significant difference among the groups. When LSD was applied, then it was found that the change in visual acuity from 7 days to 180 days in flax arcuate and manual arcuate group is significant as compared to toric group. This is the descriptive of difference of visual acuity. Previously it was the change. This is the difference of visual acuity at 7 days and 180 days among the 3 groups. And this is the ANOVA test, and it was applied, and it was found that at 180 days it was found significant. And when post hoc analysis was done, it was found that there was no statistical significant difference among the group at 7 days, but there was a significant difference at 180 days between toric and flax and manual arcuate incision group P 0.34, 0.034 and P 0.029 respectively. These are the table showing the graph showing MTF values. This is the one-way analysis of at 5 CPD in photopic condition. This is the ANOVA, and again ANOVA shows the significance at 180 days. And when LSD was applied, it shows the toric IOL group, the third group, has significantly better photopic MTF at 5 CPD. And similarly, it was analyzed at 10 CPD, and it was found ANOVA was applied, LSD post hoc test, and it was again found that at 10 CPD MTF was found significantly better in the third group, that is toric IOL in photopic condition. Then we analyzed it in mesopic condition at 5 CPD in 7 and 180 days, and this is the descriptive one-way analysis at 5 CPD. This is the ANOVA applied, and you can see it is significant at 180 degree, and then as post hoc test it was seen that it is significantly mesopic contrast sensitivity is better in toric group at 180 days. This is at 10 CPD, that was at 5 CPD, this is at 10 CPD, and at 10 CPD also ANOVA was significantly better and 180 days. And the conclusion is Lensex arcuate incision, image guided arcuate incisions and toric IOLs induced reduced astigmatism, but the astigmatism correction was less effective in due course of time in arcuates as compared to the toric IOLs. Toric IOL group achieved significantly better post-operative uncorrected visual acuity, contrast sensitivity as compared to the arcuate groups at 180 days post-op, resulting in less spectacle independence. Thank you.
Wonderful observation by Dr. Bharti Kashyap. And Dr. Jayashree Barua, would you like to comment on her presentation?
Very well presented, ma'am. So the final conclusion is that the predictability, ultimate predictability at 180 days is better with the toric lenses, you could say.
Yes.
So we need to...
Arcuates, initially it is good.
Yeah.
At 180 days, whatever everybody is presenting, but we have seen that arcuate regresses.
Okay, and that's a...
Significant regression.
and 180 days is a significant follow-up period.
Yes.
Yes, thank you.
And the next speaker, Dr. Priyam Gupta, to speak on visual outcomes in patients with corneal ectasia after cataract surgery. Dr. Priyam.
Good morning. So I'm Priyam Gupta, and today I will be presenting a paper which is titled "To Evaluate the Visual Outcomes in Patients with Corneal Ectasia After Cataract Surgery." So corneal ectasia is a progressive thinning and bulging of the corneal structures, and different phenotypes have been recognized, which include keratoconus, keratoglobus, and pellucid marginal degeneration. In-house studies have shown that the prevalence of keratoconus in the Indian population is around 0.6%, and that of PMCD is around 0.03%. It has also been seen that over the years, the population of the world over 60 is nearly doubling. Hence, the population with cataracts is also increasing. Surgeons will encounter a growing population of eyes with pre-existing corneal ectasia requiring cataract surgery. I'm sorry, this is not moving forward. Yeah. So the challenges what we face include, we have to wait for stabilization of the disease, difficulty in obtaining accurate biometry values, decision regarding IOL selection, modifications in the surgical technique, and it's very important to counsel the patient to have realistic post-operative visual expectations. In biometry, some of the challenges we face is an altered PA ratio, tear film irregularities, a longer axial length and deeper AC, and variability in the axial measurements. Intraoperatively, there can be instability of the corneal incisions and difficulty while visualization intraoperatively. And postoperatively, there can be more hyperopic refractive surprises which can be encountered. So the purpose of our study was to evaluate the visual outcomes after cataract surgery in patients with corneal ectasia. So this was a retrospective study which was done between 2016 to 2023, and 54 eyes of 48 patients were included. So from the EMR, we got the data regarding the target refraction, and at 6 weeks, we saw the BCVA, from which we were able to calculate the median absolute prediction error. So 32 eyes in our study had keratoconus, 14 had PMCD, 4 had keratoglobus, and 4 had TMCD. The mean age of the population was 51 years. Majority were males. Majority had right eye infliction, and nuclear sclerosis was the most common type of cataract. So 80% of the cases were implanted with a non-toric IOL, and surgeons preferred the Barrett formula followed by the SRKT. When we see the mild group, all these formulas did equally well, but when we see the moderate group of keratoconus especially, Barrett did slightly better, and in the severe group it was the cane. When we look at the BCVA, we see that in the keratoconus group, The severe as well as the moderate group showed a significant statistical improvement in the vision post-operatively. But the prediction error was higher in the severe group when compared to the mild and the moderate. Again, the non-toric and the toric groups did well in terms of statistical significant improvement in the BCVA. However, there were higher prediction errors in the non-toric when compared to the toric group. When we look at PMCD, again, we see that there is a statistical improvement in the vision post-operatively, but the prediction errors were again higher in the non-toric group when compared to the toric group. And lastly, we see in the keratoglobus group, there was not a very statistically significant improvement in the vision. And again, prediction errors were higher in the keratoglobus group when compared to the other ectasias. So previous studies have shown that if you have severe keratoconus, it is better to use a higher myopic refractive target. In mild and moderate cases, pentacam does better than optical biometers. And in severe cases, we can use standard K values. Some of the formulas which I have described to give accurate results are the SRKT and the Barrett formula. But again, in severe keratoconus, none of them are very accurate. Toric IOLs can be used when the central 3 mm on corneal topography has a regular bow tie pattern. There is a stable astigmatism, and patients do not require or are not dependent on the rigid contact lenses. Peripheral ectasias do well because there is better regularity of the cornea centrally, and these values are more reliable and repeatable. The limitations of our study was that this was a retrospective study where again there was a lot of different IOL models being used, and there were practice pattern amongst surgeons differed. There were economical issues where patients who were eligible for toric could not opt for the same, and it was a shorter follow-up. The conclusion is that mild and moderate KC, mild PMCD and TMCD give good post-operative results. Toric IOL is suitable in mild KC and PMCD, but unpredictable results can be expected in severe keratoconus and keratoglobus. Thank you.
Thank you, Dr. Priyam. Now we invite Dr. Alisha Porwal to speak on unlocking secrets, investigating through technology. Dr. Alisha. I would again request the speakers to be in time because we have a lot of speakers. We have to finish in time.
Good morning, everyone. Today I'll be talking on unlocking secrets, investigation through technology, how technology helps uncover hidden truths. So let's dive in. No financial disclosure. These are my table of contents. So premium IOL surgery is more than just cataract removal. It's about optimizing vision and quality of life. It has now evolved into a form of refractive surgery. For most patients, premium IOLs, especially multifocal IOLs, offer clear vision at multiple distances. However, not every patient is fully satisfied. In such cases, effective management is the key. So how do we truly know whether the patient, their visual complaints stem from the cornea or the lens? This is where the iTrace system comes in, a game changer in ophthalmic diagnostics. It combines wavefront analysis and corneal topography with iTrace. We can quantify aberrations, pinpoint the real cause, and helps in the post-operative evaluation for patient satisfaction. So this was the case of our 49-year-old patient, a tailor by profession, who came to us with progressive painless vision loss in her left eye. She had undergone uncomplicated cataract surgery with a multifocal IOL in her right eye 4 years ago. So however, her left eye had a best corrected visual acuity of 6/12 and an immature posterior subcapsular cataract. Right eye was pseudophakic with multifocal IOL with a best corrected visual acuity of 6/6. Both eyes had normal fundus and macula onosity. So given her previous multifocal IOL experience, we opted for phacoemulsification with a bifocal MF IOL in her left eye. Biometry was performed using IOL Master 700 using the Barrett's Universal 2 formula, and a suprafob region plus 26 diopters lens was implanted. For our patient, this wasn't just about the clear vision, it was about precision in a craft and an improved quality of life. 6 weeks after a seemingly successful surgery, our patient returned complaining that her near vision in the left eye felt uncomfortable despite an uncorrected visual acuity of 6/7.5 and near vision N6. Everything had gone smoothly during the surgery, so what was causing her dissatisfaction? A detailed examination was performed to identify the source of her complaints. For patients unhappy with premium IOLs, these key contributors deserve attentions which can be remembered by the 7 C's. Coming to the first C, that is cylinder and residual refractive error, as we can see, the patient had nil residual astigmatism. The second C, the cornea and the ocular surface disease. The lipivo was done and it shows a healthy ocular surface in her left eye. The third C, chronic visual disturbance. There was no positive or negative dysphotic symptoms. The fourth C is the centration of the IOL. Following surgery, the IOL was well centered and in close approximation with the capsular fornix. The fifth C is the cystoid macular edema and the ocular other macular problems. As we can see, the OCT is within normal limit. The sixth C is the capsular opacities. We found only minimal posterior capsular folds, but no significant posterior capsular opacification, as we can see in the picture. The 7C are some challenging patient. The right eye multifocal IOL was done somewhere else and required an add-on of plus 2.5 diopters, but the patient was unhappy in her left eye for near vision. So no clear reason for her symptoms was visible. That's when we turned to eye trace for deeper analysis. This was her preoperative eye trace image of the left eye showing minimal higher order aberrations. So this was the 6 weeks postoperative eye trace image and it revealed the answer. It showed elevated root mean square values and higher order aberration with a notable increase in coma, trefoil and spherical aberration, all indicating lenticular aberration. This suggested that the minimal PC fold was causing the disturbance. So we face two choices, each with its own risk and benefits, whether to go for an NDR capsulotomy or an IOL exchange. So NDR capsulotomy is a quick, non-invasive and a commonly effective procedure, but what if the problem isn't just the capsule? The second option is IOL exchange. If the IOL itself was causing the issue, that would fix it. So we went ahead with NDR capsulotomy before going to an invasive procedure like IOL exchange. So post-YAG capsulotomy, this was the eye trace image. It resolved the patient's symptoms. She was symptomatically better, and also her uncorrected visual acuity improved to 6/6, and also the eye trace showed significant reduction in higher order aberration. This case highlights the power of advanced diagnostics and a stepwise approach before rushing into surgical interventions. So these steps can be followed to optimize the outcomes with premium IOLs, starting from the preoperative evaluation, that is comprehensive ocular assessment, accurate biometry, identify the pre-existing aberrations, also patient counseling. The intraoperative consideration could be precise IOL positioning, a continuous curvilinear capsular axis should overlap the optic, and mitigating the surgical trauma. The postoperative assessment, comprehensive postoperative assessment has to be done with assessment of higher order aberration. So these are my key take-home messages. Personalized approach always wins. No two patients are the same. So customizing diagnostics and treatment is the key. Higher order aberrations matter more than you think. We often focus on refractive errors, but PCO and higher order aberration can be the hidden culprits. We should look beyond the equal visual acuity. Minimal PCO had major impact, and eye trace as a game changer. Thank you.
Excellent. Dr. Alisha, wonderful talk. And the next speaker I'm going to call
I would like to bring to the notice of the chairpersons and everyone present here that Dr. Alisha, I think your membership number is not ratified yet. So I regret to say you'll not be qualifying for any award, but it was really a wonderful presentation and we would love to hear you again next year maybe. Okay, thank you.
Surely, Dr. Jayashree. And the next speaker, Dr. Akash Sandeep, to speak on comparison of visual outcomes of Indian Appasamy and Vivinex toric intraocular lenses.
Good morning everyone, myself Dr. Akash Atode. Today I will be presenting a free paper on comparison of visual outcomes of Indian Appasamy and multinational company Vivinex toric IOS under the guidance of Dr. Amit Porwal sir. Not work. So there was no financial disclosure. So in today's world, the cataract surgeries are aiming to make the person emmetropic. So corneal astigmatism is traditionally managed using prescription glasses and contact lenses. In one of the studies conducted in India on 2502 eyes with cataract, 40% of them had astigmatism greater than 1 diopter. On another study, around 33% of the patients undergoing cataract surgery have preoperative corneal astigmatism of more than 1 diopter, with 22% having more than 1.5 diopter and 8% having more than 2 diopter of astigmatism. So various surgical options are there to treat the corneal astigmatism such as PRK, LASIK and excimer lasers. However, there are certain limitations to this. That's why the toric IOLs have become increasingly popular in today's world. So the toric IOLs were firstly introduced in the early 1990s. So among the different types of IOLs available, in our hospital, Hoya Vivinex, Alcon, Clarion and Appasomi Suprafob are commonly used. So the purpose of my study was to compare the visual outcomes and residual astigmatism following implantation of Indian Appasomi Suprafob toric and Hoya Vivinex intraocular lenses. So it was a retrospective case series conducted at Choitram Netralaya, Indore, in which 100 eyes were selected having astigmatism of more than 0.75 diopters. They underwent in the bag IOL implantation either with Indian Appasomi Suprafob toric IOL or Hoya Vivinex toric IOL. There is 50 eyes in each group. The inclusion criteria of my study was the patients with uncompleted senile cataract and nuclear sclerosis ranging from grade 1 to 4 and having astigmatism more than 0.75 diopter. Any patients with having any retinal pathologies were excluded from the study. So we did a pre-operative workup of the patient where we measured the UCVA, BCVA, IOP, dilated fundal examination, and we did the biometric calculation with Zeiss IOLmaster 700. The pre-operatively, the reference marking was done on a slit lamp. Axis marking was done in the OT before starting the surgery. Post phacoemulsification, toric IOL alignment was adjusted to correspond with the corneal axis marking. Post-operatively, the visual acuity, both uncorrected and the best corrected, was evaluated at week 4, and the post of residual astigmatism was calculated. So based on the data, the results obtained were in the group 1, the mean age was 69.24 with male to female ratio of 31:19, and in the group 2, the mean age was 63.06 with male to female ratio of 23:27. So in group 1, the mean visual acuity preoperatively was 0.86 logMAR units, which reduced to 0.009 plus, and similarly, the residual astigmatism was also reduced to -0.2 from -1.61. In the group 2, also similar results were obtained with the mean visual acuity reduced from 0.83 to 0.08, and the mean astigmatism was reduced from 1.64 to -0.4. So the toric IOLs effectively treat corneal astigmatism during cataract surgery, enabling reliable in-bag placement without corneal intervention for spectacle-free distance vision. In one of the studies conducted by Tulsidas et al., he found similar post-op UDVA for Indian and imported toric IOLs. The residual astigmatism was lower in the imported ones, but clinically insignificant, similarly to our findings. Holland et al., Yang J et al., and Seth also found comparable visual outcomes and astigmatism reduction with Indian and imported toric IOLs, consistent with our findings. The p-value of the postoperative visual acuity and astigmatism between group 1 and the 2 was 0.642 and 0.325, indicating no significant difference. In our study, none of the patients had misalignment of the axis, which was evaluated postoperatively at 6 hours, week 1 and week 4. The Faruqi J.H. et al. Found eye misalignment less than 5 degree in 71.9% of eyes and less than 10 degree in 93.8%, which was similar to ours. So coming to the conclusion of my study, both Appasomi Suprafob toric and Hoya Vivinex toric IOLs showed comparable postoperative outcomes in terms of UCVA, BCVA, and residual astigmatism. Indian toric IOLs are at par with the multinational company toric IOLs. These are my references. Thank you.
Thank you, Dr. Akash Sandeep. I'll request now next speaker, Soima Tebala. She's speaking on capturing reality anterior segment imaging of the closed globe refixation from posteriorly dislocated IOLs. Yeah, you can go ahead.
Good morning, everyone. I'm Dr. Soima Tebla. I am presenting on my paper on capturing reality anterior segment imaging of closed globe refixated posteriorly dislocated IOLs. I have no financial interest. So IOL subluxation and dislocation is seen in 1.2% of all the cataract surgeries performed. There are multiple causes like zonular weakness or pseudoexfoliation leading to loss of posterior capsular integrity. So the conventional management is IOL explantation and scleral fixation of a new IOL. But it has its set of own complications, like it requires a large clinocorneal incision. The cornea is compromised while explantation, and there is endothelial loss. The new IOL that is implanted has a higher surgical cost, induces surgical astigmatism. There's a nuisance when there is a compromised previous cornea as well. There is published data on successfully refixing 3-piece IOLs by closed loop maneuver, which compensates for the complications previously mentioned. So here's showing a video of a 3-piece IOL whose haptics are exteriorized and tucked in the scleral tunnels. But this brings us to the question, what about other IOLs, like a single-piece foldable IOL, dual haptic IOLs, PMMA lenses with dialing holes, as well as with eyelets? So we present to you a modified up-externo closed globe refixation of any of these IOLs, which works on the principle of multifocal pivot point anchoring of lenses to the sclera with a suture. The first IOL we'll be talking about is a foldable acrylic IOL. Here, this is the surgical technique where the dislocated IOL is brought to the pupillary plane with an IOL holding forceps. Partial thickness radial scleral incisions are made, and a 9-0 polypropylene suture pierces the broadest part of the haptic optic junction, and it is brought out on the opposite side by the railroad technique using a 26 gauge needle or a 27 gauge cannula. And this is a diagrammatic representation of the same. And then it loops around the IOL, and it is brought out on the opposite side via the same scleral groove. The next one is an 8-point fixation of a dual haptic IOL, in which the scleral incision is made in 4 quadrants, 90 degrees apart, and it is parallel to the limbus. Again, via the same railroad technique, 9-0 polypropylene suture passes through the opening in the dual loop haptic IOL, loops around it to be exteriorized through the same scleral incision. This is the diagrammatic representation of the same, where it loops around the dual loop haptic and it is brought out. This is performed in all 4 quadrants, and the sutures are titrated then. Next is PMMA lenses with dialing holes. These are rigid IOLs. Again, removing them is a very big challenge. So again, the dialing hole is the one which is used as the anchor point through which the 9-0 polypropylene suture is passed. And the next one is the SF IOLs which undergo suture dehiscence, and the eyelet which is present in the haptic is used for 4-point fixation. So the haptic here is exteriorized to the corneal incision, 9-0 polypropylene suture passes through the haptic, to the eyelet in the haptic, and then it is put back. So we quantify these results based on AIOS2025, which is a non-invasive and non-contact technique which provides qualitative and quantitative analysis. The corneal vertex is used as a vertical reference line, and the line passing through both the iridocorneal angles is used as the horizontal reference line. So basically, this is an interventional case series conducted at a tertiary care center in which 14 eyes of 14 patients are analyzed retrospectively over a year and a half. All patients underwent closed loop refixation with 9-0 polypropylene suture, and 3 months post-operatively the analysis was made. As we can see, this is the anterior segment image of the single piece IOL, which shows a tilt and decentration. So basically a tilt of less than 5 degrees and a decentration of less than 0.5 millimeter is considered acceptable. In dual loop haptic IOLs, as we are doing an 8-point fixation, this is considered to be a lot more stable as compared to the 4-point fixation. This is the PMMA IOL with dialing holes, in which a full thickness optical penetrating keratoplasty was also done. So especially in corneas which are previously compromised, this technique is a lot more helpful. This is this is a patient in which PMMA with eyelets, again because of suture dehiscence, also shows very good centration. So these are the details of all the patients which were analyzed. And in our case, the average tilt was 4.2 and average decentration was 0.3, which is well within the acceptable range. There have been previous studies which have demonstrated these techniques, but there was only one study which quantitated these findings based on AIOS2025. None of the other study has done this analysis based on AIOS2025, so this brings our study to an advantage. As I already mentioned, mean tilt and decentration. Visual acuity post-surgery, best corrected visual acuity was 6/9. And the mean lenticular astigmatism is the astigmatism induced by the scleral fixated IOL owing to the tilt and decentration, excluding the previous corneal astigmatism, which has come up to 0.5 diopter. The complications where there was diffuse vitreous hemorrhage seen in 2 patients and raised intraocular pressure, which were managed conservatively. This is a UV image which is showing the iris clearance, basically the positioning of the iris as well as the IOL. To conclude, scleral refixation of IOLs by closed group technique is a minimally invasive technique and has demonstrated excellent centration and tilt. The above technique can also be a promising technique to address issues related to dislocated premium IOLs. Thank you.
Thank you, Dr. Soima. Excellent presentation. And we invite the next speaker, Dr. Saujanya Kopp, to be there on the dais.
Just a question, Dr. Soumya. Did you have any case where you needed to abandon the procedure? Like for the rigid lenses, that's fine, but when you're doing it for the foldable lenses, did you encounter any case where you could not enter the needle through the optic, the thickest part? Because that's not going to be as easy as maybe the experienced surgeon is doing it, so it looks easier. So did you have any case where you needed to abandon this procedure and explant the IOL?
Ma'am, this technique definitely requires a very stable hand, and definitely initially this was mainly done by Dr. Nagesh working in Narayan Nethralaya. So yes, initially there were difficulties which were faced, but over time sir has, and plus even we are learning the technique, so yes, I think practice is what, yes, there were scenarios where we had to explant the IOL and then go on with the conventional technique. Thank you.
Next speaker, please.
Next speaker, Dr. Saujanya, and we are running short of time, so we would like the speakers to complete, and at the end, if we have extra time, then we can have comments also. So Dr. Saujanya to speak.
The slides are not working. Very good morning, one and all. So I'll be presenting the results of a trial, which is a multicentric randomized clinical trial, where we actually evaluated the effect of phacotyp position on corneal endothelial cell loss over a period of 1 month. So this was funded by Wellcome Trust DBT India Alliance Fellowship Grant. The slides are not shifting. Yeah. So minimizing corneal endothelial cell loss is very important and essential for optimizing visual outcomes. Studies have shown that bevel down phaco is advantageous as it reduces phaco time by 30% because of effective spatial contact between the lens fragments and the phacotip with no additional risk for PC rend. But the effect of this technique on corneal endothelial cell loss has not been effectively studied. Although there are few studies which have done this, there are methodological issues with inconclusive results. So this is what we wanted to study, the effect of phacotip position on corneal endothelial cell loss with the 2 techniques of bevel up and bevel down phacotip phaco emulsification on corneal endothelial cell loss. And that was our primary objective. The secondary objective was any differences in the central corneal thickness at day 1, 15 and 30, and also safety regarding intraoperative complications. So we included patients more than 18 years of age, and we excluded few patients with regards to pupil size, smaller pupil size and lower endothelial cell counts. And the intervention was bevel up or bevel down phacoemulsification with clear corneal incisions. And during the nucleus management procedure, the phacotip was kept in the position which they were assigned to. Only in a few cases, the engagement of the fragments were allowed in tilted position, but the emulsification as such took place in the assigned position. We recruited 480 participants, and a triple masking was done. That is, a participant, outcome assessor, and data analyst was blinded to the procedure. We used intention to treat principle and the ANACOA test, that is, analysis of covariance was done, where the baseline endothelial cell count preoperatively was adjusted for, and the central corneal thickness differences were assessed using a mixed effect model. This is the flow of participants, which is represented through a consort flow diagram. 241 participants were recruited for bevel up and 239 in bevel down, and at the end of follow-up, 20 participants in bevel up and 25 participants in bevel down were lost to follow-up. This is mainly during the COVID-19 pandemic. These are the differences in the baseline parameters of the population among both the study arms, there was no difference, basically indicating that the randomization happened accurately. Intraoperative parameters were also very balanced between both the trial arms. The primary outcome, which being the endothelial cell count at postoperative 1 month, was not statistically significantly different between both the trial arms. The endothelial cell loss percentage was 9.19% in Bevel up group and 9.01% in Bevel down group, which was not statistically significant. The central corneal thickness drastically increased on the first postoperative day, and it reduced over a period of 1 month, but the differences between the trial arms was not significant. We did a subgroup analysis where we tried to see if there is a difference in the interventions between those who have lower endothelial counts and those with harder cataracts, but we did not find any significant difference. Coming to the adverse events, which are intraoperative adverse events, both the trial arms did not show any significant difference in terms of intraoperative complications. So there have been several studies which have done the same trial before, but there were methodological issues. We assessed the quality of these studies using the ROB score, and we found that the previous 2 trials had some issues, mainly with respect to the sample size and the blinding of the trial. So where our trial stands robust is with the sample size calculation, with the robust trial design, and we used consort guidelines, which helps to mitigate the biases. However, we cannot generalize our results where majority of the cataracts are hard cataracts, because we have excluded the hard cataracts in our study, which was about around 11% of the cases. So we could say from this study that we can use either bevel down or bevel up position without any adverse outcomes on the corneal endothelial cell loss. Thank you.
Thank you. Thank you, Dr. Saujanya. Wonderful presentation. And the next speaker I'm going to call Dr. Nawab Jishan Farooqi. I will also request all the speakers to be present here so that after the end of the session, we will have a photo session with them.
Traditionally, simulated keratometry derived SIA is based on anterior corneal surface changes only, whereas the total corneal refractive estimate derived SIA is based on changes on the both anterior and posterior corneal curvature. Hence, there is a potential difference between the 2 methods of SIA calculation. Now, this is a prospective intervention cohort study, and the minimum sample size of 156 was based on the UN-YCL study of 0.46 SIMK based SIA and 0.61 TCRA based SIA. The patient with the senile cataract with a regular examination was included in the study, and a 2.8 mm tri-plane clear corneal incision was constructed at the keratometric steep meridian. Now, all the estimating data at 3 mm was obtained on rotating stream flag pressure disc series tomographer, and it was divided into 3 groups of ATR, WTR, and oblique astigmatism. Now, this is the pre-operative astigmatism measurement differences were observed based on the SIMK and the refractive astigmatism. In this example, there is difference of 0.35 diopters in the magnitude and 28-degree difference in the angle in the axis. This is another example showing 0.5 diopter magnitude difference and 9-degree in the axis difference. This is another example showing 40-degree of axis difference. Now, those SIA were calculated and analyzed according to the polar values method of Nisser, and this is the Excel sheet showing the calculations. Now, the demographic characters were comparable, and it was found that the pre-operative total corneal refractive astigmatism was significantly more than the simulated keratometry based astigmatism, 0.94 versus 0.74. And the SIA calculation showed that the refractive astigmatism based SIA was significantly more than the SIMK based SIA, 0.55, 0.39, and this was in all the subgroup. This was the ATR group. In the WTR group, it was 0.77 versus 0.55, and 0.63 versus 0.54 in cases oblique astigmatism. Now, this was true for the flattening effect also. It was 0.24 versus 0.15 in the ATR group, 0.47 versus 0.28 in the WR group, and 0.33 versus 0.26 in the oblique astigmatism group. Now, if we combine the results in the intergroup analysis, it was seen that the total SIA change and the flattening effect was significantly more in the WTR group compared, and it was minimum in the ATR group. Now, this was true both for the SIA based keratometry based astigmatism as well as the refractive based SIA. Now, if we get a combined result of ABC, that is W ATR and oblique astigmatism, it was fine. Again, the SIA in the refractive astigmatism derived SIA was significantly more than the chronometry derived SIA of 0.65 versus 0.52 for the total change SIA and 0.31 versus 0.28 for the flattening effect. Now discussion. The high SIA is generally an undesirable event. It may prove useful in reducing significant preoperative corneal astigmatism. The maximum reduction in preoperative astigmatism can be achieved through on-axis incision or the preoperative steep meridian incision. The off-axis corneal incision will invariably create torque in different preoperative centers. Now, the similar results of to the present study was also observed by J. Liang, Yang YC, and Nuria Gorzan and Thomas Cohen for the combined results. And for the subgroup analysis, it was in comparison with the Yang YCL study. Now, the explanation for the refractive astigmatic SIA more than the simulated chronometry SIA was that possibly due to the impact of the more central location of incision on the steeper posterior corneal curvature, there was a greater change is observed compared to the cut located more peripherally on the anterior cornea. The superior corneal incision WTR causes greater flattening of the posterior steeper meridian, reducing the ATR effect on the anterior corneal astigmatism, thus resulting in the higher SIA TCRA. And for the temporal corneal incision ATR, it causes increased vertical steepening of the posterior corneal surface, thus further adds to the ATR effect, increasing the refractive astigmatic SIA. Now, SIA is composed of two components, the flattening and torque. Burasita said that flattening is the parameter which reduces astigmatism, and the torque is basically ineffective component of the SIA. It does not take part in the, it should not be input in the calculations. Now, the torque component was insignificant in the in all our groups, and this was in agreement with the study of the Chang, who also stated that the SIA calculation should be performed using ray tracing method of total corneal refractive astigmatism. The preoperative SIMK based astigmatism was significantly different compared to TSI, both in magnitude and angle, and this can have selection errors in toric implantation and stigmatic location and the calculation errors. The SI derived from the ray tracing TSI is significantly greater than the derived from the simulated chronometry. Hence, this calculation needs to be taken into consideration for planning the astigmatism correction with or without toric IL. The steep meridian corneal incision placement result in maximum flattening a significant torque component of the SIA. Preoperative less than 0.5 adapter WTR temporal incision may be employed, as otherwise the astigmatism axis will be flipped because of a higher magnitude of SIA. The on-axis incision can be particularly challenging to perform in superior nasal infection. Hence, it is recommended to make clear corneal temporal incision in such cases of less than 1 diopter, causing the least amount of astigmatism. The limitation lacuna, the superior nasal incision was not included. This increases the risk of deformity as a result of manipulation of the finger handpiece over the nose. The SI completion based on spirometry steep meridian is based on this. Hence, the incisional flattening of SIA TRCA may not represent the actual post-operative outcome. The follow-up is of a shorter duration. Thank you. These are references.
Thank you, Dr. Farooqi. As always, one of the finest papers that he is always speaking on a lot of research and a lot of new developments. And the next speaker we are going to call Dr. Deepak. Is he there? Dr. Deepak and Dr. Happy Kaur. Any of them? Dr. Happy. Yeah. So Dr. Deepak Digambar is absent. We can mark absent.
Is the next speaker Dr. Rajshri Hirawat here? All right, thank you.
Which one? Last week, Happy Kaur.
So we have a talk from the Rajasthan Ophthalmological Society.
Okay, last one. Absolutely. Sure.
Good morning to all. Hello. Topic of my presentation is manual small incision cataract surgery under intracameral fixed dose combination of lignocaine 1%, tropicamide 0.2% and phenylephrine 0.3%. As we all know, cataract is the most prevalent cause of blindness, accounting for about 62% of the total prevalence of blindness. Cataract surgery is one of the most effective surgical intervention in terms of quality of life and vision restoration. For a successful cataract surgery, good anesthesia and effective medrace is an important prerequisite. Conventional method of pupillary dilatations are topical tropicamide 0.8% and 5% phenylephrine eye drop. They have their own disadvantages like inadequate viability, extended duration until medrace appears, subsequent requirement for subsequent administration, and corneal toxicity and systemic complication. And for local anesthesia, we have conventional methods like retrobulbar, peribulbar, subtensive, subconjunctival. They have their own disadvantages like needle-related complications, complications like retrobulbar hemorrhage, blue perforation, traumatic injury to the optic nerve.
Audio visual, please see.
Sorry. To overcome these challenges, the use of intracameral combination of tropicamide, phenylephrine, lignocaine has gained attention. And the aim was our study was to evaluate patients' level of comfort, pain perception, safety profile, as well as surgeon experience with the use of fixed-dose combination of tropicamide, phenylephrine, lignocaine in patients with cataract blindness treated using technique of manual small incision cataract surgery. So, it was a prospective interventional observational study was conducted at Tertiary Care Hospital in Jammu on 100 patients over a period of 6 months. All patients of either sex between the age group of 40 to 80 years with cataract and with pupillary diameter of greater than 6 mm on preoperative evaluation were included in the study. Patients with traumatic cataract, uveitis, pseudoexfoliation, pupillary abnormalities or any ocular disease and systemic disease were excluded from the studies. And also patients with known sensitivity to tropicamide, phenylephrine and lignocaine, and patients using drugs like alpha blockers, NSAIDs and prostaglandins, they were excluded. And uncooperative patients like with hearing problems, dementia, high degree of anxiety and movement disorders were excluded from the study. Now, after doing a detailed medical ocular history and systemic ocular examination using slit lamp examination and fundus examination using 90D and indirect ophthalmoscopy, all the patients were put on topical antibiotic drops 4 hourly, 1 day before the surgery. On the day of the surgery, topical anesthetic proparacaine 0.5% was instilled 5 minutes before the surgery twice. And no superior rectus bridal suture was given, and intracameral fixed dose combination was injected, 0.1 ml solution was injected through side port, and then CC rexus was done through side port with 26 gauge bent needle. After conjunctival peritomy, a sclerocorneal tunnel was made, the frown shape incision was given, and size was about 5 to 6 mm. And depending on the grade of the nucleus, and the delivery was done through viscoexpression, and after thoracortical wash, single piece PCL was implanted, and all the patients were operated by single surgeon, and time taken to achieve mydriasis was noted in mm using Castroviejo caliper. Pupil size was noted at the start of the surgery, 20 seconds after injection of the fixed dose combination, after delivery of the nucleus, before IOL implantation and the end of the surgery, and patients were followed up for pain and comfort on first post-op day, 1 week and later on. These are the few pictures after injection. Then sensation of pain felt during surgery was recorded on VAS scale, and quality of comfort during surgery was recorded on 5-point Likert scale. Then results, total of the 100 patients, among 100 patients, 52 were male and 48% were female. Average age of the patient was 60 years. And VAS score intraoperatively, 90% of the patient reported no pain, 10% reported mild pain. Post-operatively, 100% reported no pain. Likert scale for patient, 90% of the patients intraoperatively rated 5, that they were very much satisfied, 10% rated 4 on Likert scale. Similarly, Likert scale for surgeon comfort was 90% in the cases surgeon rated 5, and in 10% he rated 5. Pupil size at the start of the surgery it was 2.8 mm, at the end of the surgery it was 6.84 mm. And then we have different studies have quoted, they have different pupil size. In our study it was 7.61 mm plus minus 0.96 am. So in short, I can say in our study, I can say it intracameral combination, it leads to rapid achievement of mydriasis, maintenance of stable pupil during surgery, good patient and surgeon comfort, efficacious and safe. It reduces the preoperative time, and as a result total surgical time, and it is a good alternative to peribulbar anesthesia in safe in experienced surgeons' hands. Okay, thank you.
Excellent. Now I invite next speaker, Dr. Rajshri Hirawat, to speak on behalf of Rajasthan Ophthalmological Society. The topic is black diaphragm IOL in traumatic and congenital aniridia, long-term visual and structural outcomes. Dr. Rajshri.
थर्ड में क्या
क्या हुआ? शो नहीं कर रहा है, कैसे? क्या हो गया? पास करें।
पेन ड्राइव उधर दे दो फटाफट।
One of the finest sessions on cataract surgery in a free paper session of International Ophthalmology Conferences is happening here, and you are all fortunate to be witness to that with one of the finest faculty as panelists observing the whole thing. So it's a great occasion, and we would like, after the end of this talk, the speakers to be present here on the dais. We will have a group session. And in the meantime, we'd like the last speaker to complete the talk as early as possible. And Dr. Ikeda, would you like to comment on any of the papers and how is your been observation?
So she had to leave for another session actually. She's
all,
not here.
All right. Dr. Bayala, what is your observation?
I think the presentations are getting better and better day and day. And about this conference, we are getting very good papers and very good presenters. Most of them, they have told many things and they have made many things clear to the delegates and amongst ourselves. Everybody learns from these. So the era of these conferences is not over. Though there are so many webinars these days, I think that's why people for attending conferences are getting less and less. But this should go on.
Dr. Mohit, would you like to say something?
It's a great opportunity for us, and our speaker is ready, so let us listen to her.
Dr. Mukesh, how has been your observation?
Very nice.
We start? Okay, we start the session.
Yes.
Complete the talk of Dr. Rajesh. Yes, please.
A very good afternoon to all of you. So today I am going to present black dye from intraocular lens in traumatic and congenital aniridia, long-term visual and structural outcome. I don't have any financial disclosure. So intact iris and lens diaphragm is essential for the crucial vision. So combined aniridia and aphakia, this patient have distinct challenges. This patient have, slides are not moving. These patients have a special concern not only for the visual acuity but also for the glare, photophobia and aesthetic issues. It was the landmark study by the Reinhardt and Sundmaker who used the BD-IOL to manage this situation. So primary objective of my study is to look for the intervention rate and visual acuity improvement after BD-IOL and to evaluate intraoperative, early and late long-term postoperative complication. It is a retrospective interventional study, patient with congenital and traumatic aniridia with minimum up to 6 clock hour to complete aniridia who operated between 2017 to 2021 included in the study. Detailed examinations was done. IOL power was calculated using the SRK2 formula and patient follow-up ranged from 18 months to 72 months. I have used QV aniridia IOL care group. The optical diameter is 5.5 and overall diameter is 12.75 mm. 4-point fixation of BD-IOL was done using the tenno-polypropylene sutures and results were analyzed in the terms of functional outcome, positioning of IOL, cosmesis, early and late complications. Out of the 13 patients, 2 were the female and 11 were the male. The age ranged from minimum 14 years to 76 years. 4 eyes belong to the congenital group and 10 from the traumatic. Out of the traumatic, few patients has retinal detachment, vitreous hemorrhage, endophthalmitis and retained intraocular foreign body at the time of presentation. The successive table will show the preoperative data for these eyes.
previous ocular insert, surgery before implantation of BDIOL, iris defect, glaucoma treatment, and the lens status. So out of the congenital eyes, none of them had ASIUM before implantation of BDIOL. The 7 eyes in the traumatic group was on the ASIUM before implantation of BDIOL. Minimum 0 and maximum 4 prior surgical intervention done before implantation of Aniridia IOL. Out of the 14 eyes, 4 underwent primary implantation and 10 in the successive surgeries BDIOL was implanted. Minimum time lapse was 3 months and maximum was the 20 years. All patients underwent complete PPV except 1 cases in the congenital Aniridia group. All the patients showed good visual acuity improvement. The pre-op from 0.53 logMAR to post-op 5.1 and p-value was significant. Even the subgroup analysis here shows minimum 2 and maximum 3 line improvement. The maximum follow-up in the congenital eyes were the 72 month and in the traumatic was 60 month with a spherical equivalent of the 1.5 mm. Patient also shows the reduction in the glare disability and photophobia on the basis of the scale 1 to 10 and also a satisfactory cosmetic outcome. Post-op UBM shows no evidence of tilt or subluxation in any of the patients. These are the clinical images pre and post for the congenital and traumatic patients. Early complications were raised of the IOP in 2 patients, which was well managed medically and partial silicone oil removal was done. Late complication was GRT and RDU 1 patient, corneal decompensation in 2 and the IOL surprise in the 1. Out of the 14 eyes, 6 has the raised IOP, but all well managed medically. None of the patient needed glaucoma surgery or destructive procedure to control the IOP. None of the had chronic post-operative inflammations and CME and the endophthalmitis. Though we have the options of eyelid surgery, iridoplasty colored contact lenses, but their own pros and cons. Though IOL placement matches spectacle corrected visual acuity, problems of glare, photophobia, cosmetic issue prioritize the surgical method. In our study, majority of the patient has shows good visual improvement with reduction glare and photophobia and good cosmetic outcome. To our knowledge, this is the largest case series of suture fixation of BDIOL in the Indian scenario. Another larger studies by the Dr. Amar Agrawal in 2013, 11 eyes were included where the glued fixation of BDIOL was done. If we compare our results from rest of the world, our results were satisfactory, non-inferiority and better in the term of the complications rate. So our recommendations are use infusion port, RK marker, viscodispersive agent, gentle handling of IOL as fabric is very fragile, UVM to confirm the position of the IOL and serial endothelial count to look for the progressive cell loss. To conclude, BDIOL is an effective option for managing traumatic aniridia aphakia. Post-op inflammation and secondary glaucoma can be managed conservatively. Despite these encouraging findings, careful patient selection is a must until larger studies with longer follow-ups are available. So this is the largest case series to our knowledge done by a single surgeon, and these are my references. Thank you.
Thank you. With this, we mark the end of one of the most scientific and most interesting, informative session on cataract surgery. And I invite all the speakers to be present here on the dais. And I, along with Dr. Sharad Lakhotia, Chairman, and along with our co-chairperson, Dr. Vinod Bayala, Dr. Mohit Khatri as convener, co-convener, Professor Dr. Mukesh, and moderator Dr. Ikeda, and moderator Dr. Jayashree Barua, take your leave and invite the next panelists to be there on the dais to take over, and we invite all the speakers to be here on the dais for a photo session. Please do come. Thank you very much.
उधर से मंगवा के यहाँ